Muscle health, from weakness and aging to strength and recovery. When we think of muscles, images of biceps and quads often come to mind, the skeletal muscles that power our voluntary movements, like walking, lifting, and moving around. But our bodies harbor two other vital muscle types, the tirelessly pumping cardiac muscle of the heart, the muscle that makes your heart beat, and the versatile smooth muscle found in our internal organs and blood vessels, working diligently and unconsciously, like the muscles that push food through your gut or control your blood pressure. While all three are essential for life, and often taken for granted, maintaining their health is paramount for independence, vitality, and preventing serious health issues as we age. They respond very differently to illness and injury, particularly when it comes to muscle loss or dysfunction. What is systemic muscle loss? Systemic muscle loss primarily refers to the widespread wasting and thinning of skeletal muscle mass throughout the body. Unlike muscle wasting in just one part of the body, like a limb that's been in a cast for a long time, which doctors call localized atrophy, systemic loss is a generalized phenomenon. It's a significant health concern, often a symptom or complication of underlying chronic conditions, and it severely impacts strength, mobility, and overall quality of life. This profound loss of muscle isn't just about looking different, it significantly increases frailty, makes everyday activities harder, reduces independence, and is a strong predictor of increased hospitalizations and even a shorter lifespan. Chronic heart failure and systemic muscle loss, a vicious cycle. One key condition that drives systemic muscle loss is congestive heart failure, CHF. CHF often leads to a state known as cardiac cachexia, which is a severe form of body wasting that includes significant loss of skeletal muscle, fat, and weight. Think of it as extreme weakness and shrinking of the body, largely due to the heart condition. It's important to distinguish cachexia from simple disuse atrophy. While inactivity contributes, cachexia is an active, systemic process driven by disease-related inflammation and metabolic disruption, not just the simple shrinking of muscles from not being used. Here's how CHF drives skeletal muscle loss. Reduced blood flow, hypoperfusion. A weakened heart struggles to pump enough oxygen and nutrients to skeletal muscles, essentially starving them and impairing their function. Systemic inflammation. CHF triggers chronic, low-grade inflammation. This causes your body to release tiny warning signals called cytokines. Imagine your body's immune system sounding an alarm, and these cytokines are like tiny warning signals that unfortunately also tell your muscles to break down. Instead of helping, these signals start eating away at your muscle tissue, even when you're trying to build it up. Neurohormonal activation. Your body has emergency systems that kick in when you're stressed or sick, often called your fight or flight response. These systems, along with others that control your blood pressure and fluids, can become overactive in conditions like heart failure. When they're constantly on high alert, they release chemicals that tell your muscles to waste away, even when your body doesn't need to be in an emergency state. Metabolic abnormalities. CHF often leads to anorexia, which in a medical context means a significant loss of appetite or desire to eat. This, combined with malabsorption, where the body struggles to properly take in nutrients from food, often because the gut is congested or swollen due to poor blood flow, creates a negative energy balance that strips muscle for energy. Emerging research also points to a gut-muscle axis, meaning there's a strong connection between the health of your gut and your muscles. Your gut is home to trillions of tiny bacteria, often called your gut microbes or gut flora. When these microbes are out of balance, they can contribute to inflammation in your body, which in turn can make muscle wasting worse. Physical inactivity. Symptoms like fatigue and shortness of breath reduce physical activity, leading to disuse atrophy that compounds the problem. For someone with significant systemic muscle loss, simple daily tasks like climbing stairs, carrying groceries, or even getting out of a chair can become extremely challenging, further contributing to a sedentary lifestyle. Preventing and slowing skeletal muscle loss in CHF. Combating skeletal muscle loss in CHF requires a multi-pronged, medically supervised approach. Cardiac rehabilitation, supervised aerobic and resistance training programs tailored to the patient's capacity are key to preserving and building muscle strength. This isn't just about lifting heavy weights, it involves progressive overload, which means gradually increasing the challenge to your muscles, for example, by lifting slightly heavier weights or doing more repetitions over time, focusing on compound movements. Exercises that work multiple muscle groups at once, like squats or push-ups, rather than isolating just one muscle, and increasing intensity and repetitions as tolerated. For older adults, incorporating power training, exercising with speed, like quickly rising from a chair, can also be crucial, as the ability to generate power declines more rapidly with age than pure strength and is vital for functional movements and fall prevention. Even moderate aerobic activity, while not directly building muscle mass, significantly improves cardiovascular health, which indirectly supports blood flow and metabolism in your muscles. The critical role of resistance training in combating sarcopenia, age-related muscle loss beyond its benefits in CHF, resistance training is arguably the most potent intervention for sarcopenia, the progressive and generalized decline in skeletal muscle mass and strength with aging. It directly addresses the mechanisms of sarcopenia by stimulating muscle protein synthesis. MPS resistance training creates microscopic muscle damage, triggering a robust repair process that increases MPS, leading to muscle growth, hypertrophy, and helping overcome anabolic resistance, often seen in sarcopenia. Preserving type 2 muscle fibers. Aging preferentially targets fast-twitch, type 2, fibers crucial for power and speed. Resistance training, especially with sufficient intensity, effectively recruits and maintains these fibers, vital for functional movements like quickly rising from a chair and preventing falls. Improving neuromuscular function, it enhances the communication between the brain and muscles, optimizing motor unit recruitment and firing rates for greater strength output. Modulating inflammation and oxidative stress, regular resistance training can help reduce chronic low-grade inflammation, inflammaging, and oxidative stress that contribute to muscle breakdown. Enhancing mitochondrial function, it improves the quality and biogenesis of mitochondria, the energy powerhouses within muscle cells. Boosting physical function and quality of life, beyond muscle mass, it significantly improves mobility, balance, reducing fall risk, bone density, and metabolic health, contributing to greater independence and overall well-being. General guidelines for resistance training. For optimal results, aim for 2 to 3 sessions per week on non-consecutive days. Focus on moderate to high intensity, e.g., challenging enough so you can do 6 to 15 repetitions before your muscles feel fatigued, using 1 to 3 sets per exercise. Prioritize multi-joint, compound exercises, squats, lunges, push-ups, rows, that work major muscle groups. Progressive overload, gradually increasing weight, reps, or sets, is essential for continued adaptation. Always prioritize proper form over weight, and include a warm-up and cool-down. Nutritional optimization, adequate protein and calorie intake are essential. A heart-healthy diet, frequent small meals, and sodium restriction are often recommended. Nutritional supplements may help when intake is insufficient. Beyond just general protein, ensuring you get enough essential amino acids, the building blocks of protein, think of them like special bricks for muscle building, especially one called leucine, which is like a signal to your muscles to grow, is vital. Vitamin D plays a crucial role in muscle strength, function, and balance, with deficiencies linked to weakness and increased fall risk. Creatine supplementation, under medical guidance, has shown benefits in improving strength and muscle mass, particularly in conditions involving muscle wasting. Omega-3 fatty acids possess anti-inflammatory properties that can support overall muscle health and recovery. Optimizing CHF medications. Guideline-directed medical therapies improve heart function, which indirectly mitigates the systemic drivers of muscle wasting. These are different types of medications your doctor might prescribe to make your heart stronger and work more efficiently. For example, ACE inhibitors and beta blockers help relax blood vessels and slow your heart rate, making it easier for your heart to pump. SGLT2 inhibitors are a newer class of drugs that help your kidneys remove sugar from the body, and they have also shown significant benefits for heart and kidney health. MRAs, mineralocorticoid receptor antagonists, block certain hormones that can worsen heart failure. By making your heart stronger, these medications indirectly help protect your muscles. Managing comorbidities. Addressing other coexisting health conditions like diabetes or kidney disease helps protect muscle health. Muscle regeneration, the body's repair system. Beyond the impacts of disease, skeletal muscle possesses a remarkable capacity for repair and regeneration, primarily driven by specialized muscle stem cells called satellite cells. Think of these as your muscle's own repair crew or reserve cells. They usually just sit quietly on the surface of your muscle fibers. But when your muscles are injured or get a good workout, these cells wake up, multiply, and then join together to fix damaged muscle or help it grow bigger and stronger. However, in conditions of chronic illness or advanced age, the function and number of satellite cells can be impaired, hindering effective muscle regeneration and contributing to overall muscle loss. The impact of aging, sarcopenia. While chronic diseases are major drivers of muscle loss, aging itself also leads to a progressive and generalized decline in skeletal muscle mass and strength, a condition known as sarcopenia. This age-related muscle loss is driven by a complex interplay of factors, including reduced nerve signals to muscles, hormonal changes, e.g., lower testosterone, growth hormone, decreased efficiency of muscle protein synthesis, and chronic low-grade inflammation. Sarcopenia significantly increases the risk of falls, frailty, and metabolic disorders, underscoring the importance of lifelong physical activity and adequate nutrition to preserve muscle health into older age. Furthermore, sarcopenia is often accompanied by myosteatosis, which is the infiltration of fat within the muscle tissue. Imagine marbled meat, that's fat woven throughout the muscle. In people with myosteatosis, fat starts to build up inside the muscle itself, making the muscle less efficient and weaker, even if the total amount of muscle hasn't drastically changed. While hormonal interventions, like testosterone replacement or growth hormone therapy, are subjects of ongoing research, their use to combat sarcopenia is complex and requires careful consideration of potential risks and benefits under strict medical supervision. Beyond skeletal muscle, cardiac and smooth muscle. While skeletal muscle bears the brunt of systemic muscle loss, what about the other two types? Cardiac muscle, the heart muscle itself, can undergo significant changes. Initially, it might thicken, hypertrophy, to compensate, working harder to pump blood, but in advanced stages, it can also thin and weaken, atrophy, further impairing its function. This is part of the systemic wasting process in severe CHF. Smooth muscle, found in organ walls, gut, blood vessels, bladder, smooth muscle is generally more resilient to widespread loss in systemic wasting conditions. Instead, it primarily experiences dysfunction. This resilience is partly due to its unique cellular properties and its primary role in maintaining tone and involuntary contractions, making it less prone to the broad catabolic signaling that can devastate skeletal muscle mass, unless there is severe and prolonged lack of blood flow, ischemia, leading to cell death. Common causes of smooth muscle dysfunction, beyond CHF. Electrolyte imbalances, disrupt contraction/relaxation cycles, e.g., low potassium or calcium. Neurological disorders, autonomic neuropathy, e.g., from diabetes, Parkinson's disease, can disrupt nerve signals to smooth muscle. Hormonal imbalances, hypothyroidism, underactive thyroid, can slow gut motility. Inflammatory/autoimmune diseases, conditions like scleroderma or inflammatory bowel disease, IBD, can directly affect smooth muscle. Genetic disorders, rare conditions like multisystemic smooth muscle dysfunction syndrome directly impact smooth muscle proteins. Medications and toxins, opioids, causing constipation, anticholinergics, causing urinary retention, or certain toxins can interfere with smooth muscle. Ischemia, mild to moderate ischemia can cause smooth muscle cells to become dysfunctional due to lack of oxygen and nutrients. Severe ischemia causes cell death and tissue loss. This dysfunction can manifest as issues like chronic constipation due to poor gut motility, gastroparesis, delayed stomach emptying, often seen in diabetes, or orthostatic hypotension, a drop in blood pressure upon standing, due to impaired blood vessel smooth muscle function. Reversibility of smooth muscle dysfunction. Acute causes. A key distinction is that smooth muscle dysfunction, especially when due to acute causes like an electrolyte imbalance, can often be rapidly and significantly reversed by correcting the underlying problem. This is because the muscle cells are usually still alive, their ability to contract or relax is simply compromised. Chronic diseases, however, if smooth muscle dysfunction is due to a chronic, complex disease like heart failure, the improvement will be gradual and tied to the overall management of the heart failure. The systemic inflammatory and neurohormonal changes take time to mitigate. Ischemia. While mild ischemia can cause temporary dysfunction, severe or prolonged ischemia can indeed lead to the death of smooth muscle cells. This process, called apoptosis, is a type of programmed cell death, where cells essentially receive a signal to self-destruct in a tidy, controlled way, unlike a messy, uncontrolled cell death from injury. This results in a permanent loss of tissue, seen in conditions like intestinal infarction or severe ischemic priapism. In such cases, the body's own repair mechanisms and the natural ability of tissues to adapt and change, plasticity, try to heal the damage. However, this often results in fibrosis, which is the thickening and scarring of tissue, forming tough, non-functional scar-like tissue that can permanently affect organ function, much like a scar on your skin. Pelvic floor muscles and hernias, skeletal versus smooth. Pelvic floor muscles, the muscles you voluntarily control and train, e.g., with Kegels, are primarily skeletal muscles, e.g., levator ani, external sphincters. However, the pelvic region also contains vital smooth muscle components within organ walls, bladder, rectum, and involuntary sphincters, internal anal sphincter. Hernia. A hernia is fundamentally a structural defect or opening in the skeletal muscle and facial layers/fibers of the body wall, through which internal organs can protrude. These facial layers are tough, sheet-like bands of connective tissue, like strong, flexible wrapping, that surround muscles, organs, and other structures, providing support and stability. It is not primarily a smooth muscle issue. This defect can be a widened natural opening, e.g., in the groin or navel, or a splitting/tearing of these facial fibers. Weak spot versus true defect. A hernia often begins with a weak spot, an area where the facial or muscle tissues become thinned, stretched, or generally less robust than before. However, in medical terminology, when this weakness progresses to the point where an organ or tissue can actually push through and form a palpable or visible bulge, that compromised area becomes the defect or opening. While not always a clean-cut, surgically precise hole, it represents a functional breach in the body's natural containment barrier. It's a place where the continuous outward pressure from within the abdomen has caused the integrity of the wall to fail, allowing something to protrude. Because a true hernia implies this structural breach, exercise generally cannot fix or close an existing hernia defect. It's a structural problem that usually requires surgical repair. Exercise, however, is invaluable for prevention, by strengthening core muscles before a hernia develops, and for post-surgical rehabilitation, to support the repair and build overall core strength. Other causes of abdominal wall bulges, non-hernial. Many other conditions can cause a bulge, where the underlying issue is muscle weakness or separation, but without the specific hole or defect that defines a hernia's protrusion through a facial layer. Lipoma, a benign fatty lump under the skin. Hematoma, a collection of blood under the skin. Generalized abdominal wall laxity, overall weakness of the abdominal muscles can lead to a diffuse outward bulging or lack of containment without a focal defect. Exercise can help improve overall tone here. Tumor, a growth, benign or malignant, within the abdominal wall. Diastasis recti. This is a common separation of the rectus abdominis, six-pack, muscles along the midline, linea alba, which is a tough, fibrous band of connective tissue running down the middle of the abdomen. Especially common after pregnancy, the linea alba is stretched and widened, allowing the two parallel bands of the rectus abdominis muscles to separate from each other, moving away from the midline. The bulge seen is the underlying abdominal contents pushing outward because the overall muscular compression is reduced, but there isn't a hole in the linea alba itself that allows organs to push through it in the manner of a hernia. Targeted deep core exercises, e.g., transverse abdominis training, can improve alignment by strengthening the deep core muscles and helping to approximate the separated rectus muscles, but poorly selected exercises like early crunches can worsen it. Diagnosing a hernia. Physical exam. A doctor will assess the bulge by palpating, feeling it, often asking the patient to cough or strain, a maneuver called the Valsalva maneuver, which involves taking a deep breath, holding it, and then bearing down or trying to exhale forcefully against a closed mouth and pinched nose, similar to what you might do during a bowel movement. This action temporarily increases pressure inside the abdomen. If a hernia is present, the doctor will feel a distinct hernia impulse, a sensation of the internal contents pushing against their fingertips as they momentarily protrude through the defect. They can often also feel the distinct edges of the defect itself. In many cases, the doctor can gently push the protruding contents back inside the abdomen, reduce the hernia, which further allows them to feel the precise size and shape of the defect. Imaging for confirmation or ambiguity. While a physical exam is often sufficient, imaging studies are crucial in certain situations. If the physical exam is inconclusive, or the hernia is very small or difficult to feel. In obese patients, where excess tissue can obscure findings. To differentiate the bulge from other conditions like lipomas, tumors, or diastasis recti. For complex or recurrent hernias, to understand the full extent of the problem. Common imaging tests include ultrasound, CT scan, or MRI, which can visually confirm the presence of a defect and the protrusion of internal contents. Conclusion. Our bodies are intricate systems, and muscle health extends far beyond just enabling movement. It's fundamental to our independence, vitality, and overall well-being, especially as we get older. Systemic skeletal muscle loss, a debilitating outcome of chronic illnesses like heart failure, significantly impairs strength and quality of life, increasing frailty, reducing independence, and raising the risk of mortality. The natural capacity for skeletal muscle regeneration through satellite cells, your muscle's repair crew, while remarkable, can be hindered by disease and aging. Age-related muscle loss, or sarcopenia, often compounded by myosteatosis, fat infiltration within muscle, like marbling in meat, presents its own challenges to mobility and metabolic health, underscoring the importance of lifelong physical activity and adequate nutrition to preserve muscle health into older age. In advanced illness, cardiac muscle may undergo hypertrophy, thickening, or atrophy, wasting, while smooth muscle tends to develop dysfunction more readily than it experiences widespread loss, partly due to its inherent cellular properties. Fortunately, Smooth muscle issues are often highly reversible, especially when underlying causes, such as electrolyte imbalances, are addressed promptly. Nonetheless, severe ischemia, lack of blood flow, can cause irreversible damage through processes like apoptosis, a controlled, programmed way for cells to die, ensuring a tidy cleanup, or lead to fibrosis, the formation of tough, scar-like tissue that can hinder normal organ function. While your body's own repair mechanisms and the natural ability of tissues to adapt and change, plasticity, play a role in recovery, this often comes with limitations and scarring. Understanding the nature of muscle conditions is essential, particularly when distinguishing between loss, dysfunction, and structural defects. For instance, a hernia represents a defect in the skeletal muscle and facial layers, the strong connective tissue sheaths, and typically requires surgical repair. This differs from conditions like diastasis recti, which often respond well to physical therapy. Identifying the type of muscle involvement is the first step toward effective treatment. Beyond the physiological aspects, it's crucial to acknowledge the psychological and social impacts of muscle loss. The reduced mobility and independence can lead to feelings of frustration, anxiety, and depression, further exacerbating a sedentary lifestyle. Social support and mental health interventions can be vital components of a holistic management plan. While the body can compensate, and sometimes regenerate, outcomes depend heavily on timely, targeted intervention. A consistent regimen of chronic disease management, nutrient-rich nutrition, including specific vitamins like vitamin D, minerals, and amino acids, and appropriate physical activity, including tailored resistance and power training, remains one of the most effective strategies for preserving muscle strength and overall physiological function throughout life.